gonna talk dementia today, and you never know where else things will go because we're doing a real show, as Jenna said.
We've had a number of shows, James, where we've met conversations that have got nothing to do with health.
Well, they're life conversations, right? We just kind of end up talking about things that are on our minds, and I love those conversations as well. That's kind of fun. Actually, I was just putting a show together, and it was a power work show with Glenn, and we were talking about your Land Rover Pajero situation. So I thought that was kind of fun.
What's the situation with my Pajero?
Where you like the Pajero for getting the three. You like the Pajero, but the three seats fit better in the Land Rover.
So you know what? The Pajero was not a car that I wanted. I didn't think it was pretty. It just wasn't for me. And oh goodness me, what? Why did you say that before, James? This is your fault. I absolutely love the Pajero. I love it. And if we could get three seats in the back, or if you could turn the airbag off at the front and put one in the front seat, it'd be brilliant. I love the drive. It's quite a hard drive. It's such a great car.
Yeah. Well, there you go. I think you're the only person I've ever heard say that. But that being said, I'm happy that you really love your Pajero, and that's a great thing.
You know, I moved to Australia after university for a year, and my dream was always to have like just a little 4x4.
Yeah.
And I had a little mini 4x4. It was great. It was great because I liked having it and the novelty, but it was a terrible car. I mean, it would come out of gear. It would the battery would go flat all the time. It was a really terrible car, and it ended up going for scraps when I sold it, or I didn't sell it. I basically got a few $100 for giving it away for the scrap. However, the Pajero actually reminds me of that same kind of drive and feel about it, and I think that's why I like it.
Oh, cool. I mean, that's always.
But yeah,
I think
look what you've done. You've got me talking about things that aren't to do with health again.
Well, it's the warm up. It's the lead in as we get going on things, because it's important to warm up the vocal cords and get the mind going.
But maybe I'm sensitive to it, James, because I feel like I'm becoming a doctor of life. You said we have conversations of life. My page, nothing's about health anymore. It's all just about life. I quite like it. I feel like maybe this is just my direction now.
I think there's a fine, it's kind of like the magic dust between hardcore medical issues. If I take this, it's going to have that effect, and my blood pressure, my cholesterol, and what's going on in our minds and how that all starts to influence things. And I think those lines are pretty separate in a lot of cases when you walk in the door and people have the stethoscope or the white coat or the way the whole rooms are set up. And I think there's a lot more ambiguity. And I think when we start putting all the pieces together, and in fact, we're going to talk about dementia. That's where we're going. But before we get in there, I wanted just to jump in on something that's really interesting, and we will get Sheryl Wasama onto the show sooner than later, because the number of people I've been talking to in the last week that have had panic attacks, and I mentioned this to someone, and I said, I just was talking to someone, and they're talking about panic attacks, and the person said, my daughter has panic attacks now all the time. She never had these, and now she, and it's tightness of the chest. It's like people feel like they're having a heart attack. They're truly scared, and then that escalates things. That's that whole doctor of life thing where,
Well, funnily enough, a lot of my patients used to come to me about things that weren't really medicine, and a lot of them were just life issues, and they just wanted to talk it through. And yes, they can have knock-on effects into giving you real physical symptoms, but sometimes they just wanted to talk or to get out of their everyday life, to just check in with somebody. And so I had a lot of life patients, as it were. And yet, I think at the moment, the situation, people aren't coping. We had this conversation 12 months ago, and it's only been compounded by the fact that COVID is still going on. People thought once they had the vaccine, that was it. They'd have their freedom. They'd get reunited with their family and friends. They still aren't. And I know, gosh, even myself, as soon as I think it was just before the 17th of May. Hang on, 17th of May is today. So today, everything in the UK was supposed to open up with regards to travel. And we all knew deep down it wasn't going to happen. But the minute they pinpointed our region, the UAE, as being an area that was indefinitely going to stay on the red list, and that meant you can't go back home unless you have to do a hotel quarantine. Gosh, I know it's affected me and lots of my friends. So even from personal experience, I can understand. So yeah, there's a lot of panic attacks, and we get loads of panic attacks into A&E, by the way, lots of them. And sometimes there is a really fine line between, is this a panic attack? Is it a heart attack? And it's not until you start doing appropriate testing that you can actually figure out which one it is.
Yeah, no, it's deep breaths, deep breaths. And as you said, and you know, with the timing that we're doing this podcast today, you know, I found the amount of time that I now start investing in myself. And that's just doing a little bit of exercise, or, you know, a little bit of a run, scale that back up, scale back that down, started swimming again, which is just fantastic. Got back in the water and did a kilometer, and it was just, why have I not been swimming recently? So I was really happy with that. And then just getting a little workout in. It's amazing how that changes your mindset. And I know people are going, come on. It's like, no, you know, I do a little circuits, a little bit of swimming, and I feel so much better just in that disposition when I'm looking at work and I'm thinking of things and I'm looking at the world around me. It's amazing. It's self-care. We need to be a little selfish and say, yeah, I need that half hour. I need that 45 minutes for myself to go and do X, Y, Z just to keep the brain focused.
And that's so true. Exercise is definitely, it's the best medication for anxiety and depression, for sure. However, I think sometimes people get a bit put off at getting into it, especially if they are suffering with anxiety or depression. And sometimes you've got to think, right, maybe I'm not up for that big run, or I can't face going to an exercise class with people around. So just think, what could I do today? And maybe a brisk walk might be day one. And then you think, oh, actually, I feel a bit better after that. And maybe day two, you can add something else in. Do it in your bedroom, do it in your jumper, do it in your baggy t-shirt, whatever way helps you to get on the ladder of exercise will really help. Because once somebody is at the point where they're having a panic attack, it's actually much harder to talk them down and reverse it. These people generally feel like they're dying. You know, their throat might feel tight. They don't feel like they can get their breath in. And it's very hard to tell someone in that mindset, you're absolutely fine. There's nothing wrong with you. Just take deep breaths. So it's almost like, let's try and prevent it first.
And it doesn't go away right away either. That's one of the things that I've noticed is when people are having panic attacks, they have it, and all of those physiological things, they hang around for days. And it's really hard when someone wakes up in the morning and they're still feeling, you know, did they call this right? What's going on with me? Why is this still here? Why am I not feeling my normal, jovial, plasticine self? So I think...
Sorry, James.
Go ahead.
I was going to say, it's hard to think about it. If you get yourself to such an extreme point in your general physical health that you stop being able to function. So say you've had a really bad illness, there'll be an incline to feeling so bad, and then there'll be a decline back to your normal health status. So if your mental health and your anxiety gets so bad that you incline all the way to the point that you feel like you're dying and you can't cope anymore, the world is almost ending, this fear of impending doom, then you have to go all the way back again. And I've spoken to quite a lot of patients and friends who were suffering quite badly with depression. And I think, as I say to them, you've got to just ride it out, accept it's not going to get better the next day, 2 days, 3 days. It's the long term, but it will get better. Just sit with it, accept it, acknowledge what it is, and accept that at some point either medication or talking therapies, whatever it is, will kick in and you will start to feel better, but it takes time. And I said to you just before we started to record, how impatient I am for various different things in my life. We're all impatient, and as patients, we're impatient as well.
Exactly. Which, you know what a nice way to start off, just getting us thinking about ourselves. I want to jump right into our dementia conversation, because this is one of those things that this is a great word. Dementia is a wonderful word in that as soon as someone says that word, we start attaching all of these mental labels to it. And again, just like, and so the linkage here in my mind, follow me here, is when we talk panic attacks, people start attaching a whole bunch of thoughts to it, and we start attaching thoughts to it. Not that dementia and panic attacks are at all alike. They're not. But where, to me, the linkage is that this term carries with it so much baggage, dementia, that when it gets used, people have all sorts of ideas about it. They always know somebody who's had some form of dementia. Many people have an experience with it. And then people are starting to think about themselves, and they start looking at, as you start to get a little bit older, so maybe you're in your late 40s, 50s, mid 50s, heading into your 60s, your memory might not be getting as good. You might notice you're stumbling on whatever. And people start thinking, oh, what's going on? Am I in early stages of dementia? And we often think dementia, Alzheimer's. Now, there are things that work together there, but they're not the same thing. And I find these terms just start to get all jumbled around. And I think this is a great opportunity to sort of lay out the groundwork and some of the things that are going on with it.
I think as well, if you watch on television someone that's portrayed as having dementia, they usually show somebody that all of a sudden gets lost when they're out. They're leaving their hob on and they've gone off for a walk, and it's quite extreme behaviors. And somebody yesterday was absolutely fine. So yeah, I think it's good to put down on the table what exactly is dementia, what are the different types of dementia, and how does it present? Because people they panic and they get confused about it. And the first thing is, you mentioned Alzheimer's. They're not interlinked. You can't say Alzheimer's and dementia as the same thing.
I find people put them right together. They say, they've got dementia, they've got Alzheimer's. It's like, well, hold on a second. We're talking different things. I mean, similarities, and there's a connection, but one isn't necessarily the other.
Well, dementia encompasses a number of different types of memory loss, of which Alzheimer's is the most common. So for people to put them together, it's not right, but you can sort of understand why, because 60-70% of people with dementia will have Alzheimer's. And what is different is how the dementia occurs. So you've got dementia, main heading, subheadings, Alzheimer's number 1, and these are like little plaques that progress in the brain, so stops it functioning as well as it should. And it's usually around the posterior aspects of the back of the brain. But then you also have like a vascular dementia, which has a very different presentation. And that's where you have little tiny micro strokes. And by strokes, basically the blood can't get to certain parts of the brain, and that little part of the brain dies. And they're only very small, but they're scattered around, and over time it gets worse. And that's quite different. Whereas Alzheimer's tends to get worse over time gradually. The person's not always fully aware of what's happening to them. People with vascular dementia are very aware of what's happening, and they can get quite embarrassed about it. And there's big stepwise processes as these mini strokes come on. So they can be doing quite well, and then all of a sudden they have another mini stroke, and the progression is quite great. You also have
with vascular dementia. I got a quick question with vascular dementia. Is there an age sort of thing with vascular dementia as well, where as we're getting older, there's a better chance we could have that? Or is anyone open for these little types of mini strokes that happen? And
that is usually all types of dementia usually occur more as you get older. So they're all sort of more common as you get as you age. You can get early onset Alzheimer's, for instance, which is usually, I think it's below the age of 65. However, as you get older, there's always going to be an increased risk of most diseases, to be honest, James. Generally, as we age, things just stop working as well, and everything slows down a little bit. And as I said to you, we were talking about cancer, weren't we, recently, about how when we make new cells, things can go wrong as we get older, and we're not as alert at being able to identify things that aren't right in our body. It's the same for everything. So yes, more common as you age. And there are lots of other types of dementia that are less common, like Lewy body dementia.
I like that one. I found very interesting.
Alcoholic dementia.
I found the Lewy body dementia very interesting as I was reading about this.
Why?
I don't know. I think the one reason was I'd never heard the term, and when we're talking about the different types of dementia, so that term had never really come up, and so it just grabbed my attention, and I was it's just kind of looking at this and going, okay.
It's much less common, and you get Lewy bodies in parts of the neurons in the brain. But the dementia that I love, and take that lightly when I say I love, the most fascinating type of dementia is Korsakoff's, and that's a type of alcoholic dementia.
Hmm.
And you get people that engage in confabulation. So they, for instance, say I've forgotten the word James. I'll just start calling you by a different name and try and pretend I've forgotten your name and I've just made something up. And they are fascinating. And sometimes they'll tell you entire like tales and stories that didn't ever exist about how they were the prime minister in Zimbabwe. And they can give you this story right down to the detail, and it's all just a story to compensate for the fact that they've forgotten the real story that they want to tell you. And I find that completely fascinating. But to be honest, they all are, and the patients, if you meet them, can be exceptionally fascinating people.
So how can we slow it down, Jenna? I mean, when we talk dementia, there's these different plaques, as you've called them, different types. Are there any commonalities between them that people who are listening right now, who might be thinking to themselves, they inevitably thinking about their families, their parents, their aunts and uncles? See, I did that English style, aunts. I called it an aunt instead of an aunt. I'd call it an aunt. My aunt. I wouldn't call my aunt an aunt. But
well, because I am Northern England, I also call it an aunt.
My aunt. There we go. Okay, so we're in.
But if I was more well-to-do, James, I would call it an aunt, my auntie. But no, I'm not well-to-do enough for that. The only commonality between trying to delay them is really basic stuff. And we talked about medicine of like life, and it's just exercise, eating well, being aware of it. Some people talk about memory games, but that's more just to generally keep your mind alert. It's not going to stop the onset of Alzheimer's, Lewy body dementia, Korsakoff's, whatever it may be. Not drinking too much alcohol, having a healthy, balanced diet, just very, very basic stuff, to be honest. And sadly, there is a genetic component to these things. So often, if your parents have had dementia, especially if it's early onset, there is a higher chance that you will, but it's not set in stone. Doesn't mean it's definitely going to happen.
Do people get genetically tested for this? Is that something we see happening more and more, or not really?
No, not really. It's just one of those things that maybe you would at some point decide to go and get regular memory tests, but would you want to know?
No.
The thing is especially with Alzheimer's, there are treatments that you can take, and vascular dementia, which can, in the early stages, can help delay it from progressing, but it's not a cure, and it won't hold it off forever either. And I often feel quite torn, because when I talk about dementia with family and friends and we chat about it, I can't decide how bad it is. Is it that it's worse for the family, or is it worse for the person that's going through it? Now, for someone like vascular dementia that's very aware of what's happening, that's quite traumatic. But for a lot of patients I've met with Alzheimer's disease, they are quite unaware of what's happening. And usually, for most people, they're pleasantly confused. And I think what a lovely way to go into your old ages, when you're starting to lose the ability to do things for yourself, to be in quite a nice place. And I really don't know what's best. I wouldn't want to know it was coming, but if one day I'm sat singing Les Miserables in a home somewhere to myself, quite happy, is that the worst thing in the world? Or would you want to be a really elderly person that's watching themselves deteriorate? And I haven't got the answer. I'm not sure. I'm kind of quite curious actually as to what you think.
I wonder, on the patient side, the person who's experiencing this dementia, and maybe it's Alzheimer's, I always wonder, when is the point where it's early onset, it's coming, it's happening. Where's the point where you realize and you're cognizant of that happening, to the point where you're no longer cognizant of it happening and it's just happening? And I always wonder where that point is. And I just wonder for myself, right? I just wonder if this is something that happens to me. And I'm thinking of my own family, mother's side, father's side. This is not something that I've, when I think of my grandparents, none of them seem to have experienced any kind of, my grandmother was pretty darn old when she passed away, 98. she was just slower, right? And things. So I just wonder what that point is. Just, and I think I fall in with you that, why do I wonder what the point is? Simply so that I can make sure that I've put everything in place by that point. So I've got some help or some assisted living, or I'm at home and I've got a nurse that's going to come, or a caregiver that's going to come by just to check up. So I always wonder about that.
Yeah, and I guess that probably is the stage where it's more traumatic. They're not aware of when they forget things necessarily, but they're being told that this is happening to them. And I totally understand that's not a great phase to be in for anybody. And I guess that's the same with anyone that's got a chronic illness diagnosis. It's really hard to accept.
Well,
And
I'm going to interrupt you for a second. Part of the reason I find this interesting is because you'll meet people and they've got family that are in some stage of dementia or some form of dementia. And you'll talk to them and say, I'm never going to let that happen to me. Yet inevitably, those people who are saying, I'll never let that happen to me, it happens to them because they're talking, and then it just happens over a period of time and there's nothing you can do. And it's just there. So I find that I think that area of study, the transition period, when does it go? I'd love to read more about that.
And as I say, it's less likely a day. It's just so gradual that people aren't even aware of it. But there was something that you mentioned before that I think is really important that we talk about. When you have a family member that has any form of dementia, whether it's, doesn't matter what the root cause of it is, the initial instinct of a lot of families is to say, well, I'm never going to let them go to a home. I'm going to make sure they stay at home. I've known families have split up about it.
Really?
They no longer talk to each other because of the anger towards one family member that feels it's more appropriate to put them in a home. All I can tell you is I've worked with lots of people that have dementia, especially when I was a medical student. Actually, I spent a long time on old age psychiatry. And the takeaway message for me that I came away with was, God forbid, if that happened to a member of my family, I would want them to go into a facility. And the reasons are the routine. It's, people that have got dementia of any form do very well with a routine. So when they move from their own home into, whether it's a nursing home, a residential home, a psychiatric unit, whatever it is, they've got a very set routine. So they initially may decline slightly because they're going from one environment to another, but then they have on the clock, they get their meals, they're going into the same bed, nothing really changes. It's usually around the same people that they're seeing every day. And that's really, really good for somebody that's suffering with dementia. It really helps them to keep going for a little bit longer. Secondly, the safety. It's very hard to keep somebody that is gradually losing, their memory and their ability to function normally, to keep them in a safe environment. They're not going to have to worry about electricity, leaving on gas hobs, whatever it may be. It's much safer. There's locks on the door. These people can be really adamant that they're going out to go and see maybe a mother that's passed away, 20 years ago. And they're adamant in their mind that that's what they're off to do now. And the other thing is these people over time can get quite aggressive. So for the safety of the people around them that are watching them, especially as things really start to deteriorate. And it's because they can't understand why you're saying no and why you're telling them something's not necessarily true. So for me, I think, especially if you look at the longer picture, it's better. And there will be a point if they live long enough that if it progresses to the extent that they start to lose their ability for toilet functioning, et cetera, that it's better to have all those people there that can help and on hand. So as long as you get the right place, I personally don't see any harm with it. And I know a lot will disagree, but that was my take home message is, God forbid if that happens to my family, that's what I would want.
Yeah, it's as you said, it's very polarizing, and families break up about this, and there's a lot of guilt, I guess, as well, when people think about their family members and sending them to a care home versus getting a suite in your own home or converting a part of it and maybe getting home care. There's still going to be an overlap period where you've got to deal with that, and I sometimes wonder if a hard part is just our own memories and perceptions of those family members. And we were, if it's your parents, you remember them when they were, when you were young, when you were a teenager, you remember your parents, and now you're much older and your parents are in this matured state, and possibly they're in some form of dementia, and it's kind of like, that's not the person I remember. And it's a real tough one. And as you said, there's no easy answers. There's lots of reasons to think maybe I'm going to need more help here, and maybe that help's just not going to be possible at home. But it's
Yeah, and I
interesting.
think a lot of people see it as a badge of honor, is of guilt of I've got to do this. I must do it. My parents have been so good to me. I want to do it for them. And the reality is sometimes you doing it isn't always the best thing, especially as things progress. I mean, how do you cope when they're trying to get out the front door, they're getting aggressive? It's very, very, very difficult, and it's a fragile situation. And that's why when you're looking after somebody that has dementia, you have a whole team of people. So you have the doctors, you have the family members, you have like social workers, caregivers, you have a whole team of people that manage their care. And it's because there's so many different elements to it. One of the big things is what do you do with their money? Like, who's going to manage their money?
Sure.
And sometimes these people, especially in the early stages, can want to go out and spend all their money, or they can believe that family members have stolen the money from them,
Yeah.
and it can be very, very difficult. And it also depends on how they go. I said a lot of people are pleasantly confused, and I think that's a nice form of dementia, and that has a nice, it's more calming for family members to see. But for some people, they're terrorized, and they have like quite a terrorizing dementia where they're effectively in a bad nightmare every day, and that is absolutely horrendous to watch.
I've shared this story with you before, but I'm going to share it again because it just highlights how different people deal with family members who are in various stages of dementia. And a good friend of ours had a parent in the UK who was living alone, and the house had been outfitted, as you said, with the hobs on the stove so that they had to always press it so that it would stay on. And if they didn't press it, it would turn off, and things like they'd really done the job. This person lived alone. And when the family would go and visit, there was lots of family around that would go and visit because they were still pretty good at taking care of themselves. But family still wants to go visit, and the family seemed to have they were at odds with how to deal with this, and some of the members of the family just found it so sad and difficult to deal with, and others just sort of said, "This is how it is." And the example is, the person in question just couldn't remember what people said to them. So, you would come in, oh Jenna, how are you? And then 5 minutes later, so Jenna, what are you doing for a job? And then you'd say, oh, I'm a doctor and I'm doing that. And then 5 minutes later, so what are you doing for a job these days? And so, the memory was that fluid, and part of the family they just couldn't deal with it. They would get angry. Well, I just told you 5 minutes ago. How can you forget? And the other side of the family would just give new jobs every 5 minutes. What are you doing now? Oh, I'm an astronaut. That's so incredible. And the person, and then, 10 minutes later, what do you do? I'm a brain surgeon. What an incredible job. And it was, it was just, and then the other family would get mad at them. Why are you doing that? Why are you telling me? Why not? Right? And it's how people are dealing with these things. And I find it just so incredible that dynamic that starts to exist between family members as you're going
Yeah.
through this change, which seems to hit. I don't know the stats, but as you said, there's a pretty good significant number of people in our population who have family members or themselves will experience dementia. It's pretty high.
Yeah, it is. It's surprisingly common. And again, I don't have the statistic to hand either. But you know, I, again, you touched on something. There would be people that would come up to me on the ward and say, "Are you the 46 bus?" And sometimes you'd think, is it kind of to say, "Oh, there's no bus coming today. I'm so sorry," or is it kind of to say, "Oh, I'm not, but it's just coming along now." And I think sometimes people feel like that's been quite disrespectful to do the latter, but I don't know. I think as long as you're being respectful, as long as they're happy
Right.
and you keep someone happy, is there the need to correct them every 2 seconds that they're wrong? And as you mentioned, it's usually the short-term memory that is affected. So these people will be able to recite everything that happened to them as a child, find details about their parents, etc. But when it comes to something that you've just told them, and there is something called, there are lots of different memory tests, but what we tend to use, for instance, in an accident and emergency is a mini mental state exam. It's usually all present day things, and you give them like 3 things to remember. I'm going to say to you now, James, table, apple, penny. I want you to remember it. We'll talk about something else, and like 5 minutes later, I'll ask you those 3 words again and see if they can still remember table, apple, penny. Can they tell us what the season is, what year we're in? Very basic present day things, because that's the memory that's usually affected more.
One of the things I often hear people talking about is herbal remedies or, vitamins. If I take these vitamins, it's going to help me with dementia down the road, or it's going to help me, help my brain regenerate, or do you buy into any of that?
I don't know. I've always been a believer of a multivitamin and a cod liver oil tablet or
Really?
something
You take
else.
cod liver
I
oil?
I don't, because I'm vegetarian, but I always tell my patients to.
It's fish.
That there's been
It's fish though, and
it's
it's
fish,
oil.
yes, and I didn't. The first time someone told me to take it, I hadn't thought cod liver oil, didn't think about it, and then I took one, and I was regurgitating like fish all day,
Yeah,
and
but
I've not eaten fish since I was 12. I was like, this is awful. So there was another tablet you can take with like seaweed. I can't remember the elements, but you can actually look. There's two particular important elements that are in cod liver oil. It's something like, it's not BPA, but it's something along those lines. And you can also get them in seaweed tablets as well, but they're very hard to come by. They're very expensive. And I have no problem with somebody taking that. It's also great if somebody's had a heart attack, you put them on a cod liver oil tablet. It's shown to be very effective in stopping the progression of a further heart attack, in line with their medications. It's a really good adjunct to use. So no harm in that. Whether it stops dementia, I don't know. As I say to you, it's a healthy living, isn't it? Generally, healthy living is a real great thing for a whole myriad things. But whether it really stops it, I'm not sure. It can maybe hold it off, or I don't know, James. It's a hard one, isn't it?
yeah, yeah.
I don't think it's an exact science.
I think this is a real challenge, and this is one area I don't want to get a job in, quite frankly. Just so you know, it's like working in this area of dealing with dementia, as interesting as it
Really?
is, yeah, not one that I'm jumping at. It's like
James,
no.
you know what? I loved old age psychiatry, and if I could not do all the other psychiatry training, and the reason being is I find some psychiatry quite traumatizing. For instance, people that have got psychosis, etc. It can be quite scary, especially when these patients are often very threatening. And that really put me off wanting to go down the full psychiatry training. But old age psychiatry, I found really nice. I really liked it. I think, as I say, the majority of these people are quite sweet and pleasantly confused, and it's almost quite nice to sort of live within their fantasies and to talk to someone that is completely making something up and telling you a whole complete fable. It's quite interesting to see, and I'm not saying I'd want it to happen to my family necessarily, unless they were very pleasantly confused. And the same for me. There's no right answer. I've just said it's not an exact science. It's not, but I do like old age psychiatry. I think a lot of it is very nice. It's a nice specialty. Nothing in medicine is nice, because ultimately, if you're seeing somebody, it's because it's a time usually of distress. But it's one of the nicer specialties, providing the family are quite accepting and understanding, and that the person is pleasantly confused and not traumatized by the experience.
And that's the wild card, isn't it? How is the family and all those different personalities going to be able to deal with this ongoing situation? Actually, you know what? I was just thinking about people I know who might even be self-diagnosing with early onset of dementia symptoms, and I've known a few people who've up in their 70s and 80s who clearly have recognized that they're not remembering some things, and they've become excellent list makers and reminder makers. And I've seen this in a couple of occasions, and you're walking by something, oh, that's quite a good reminder list there. And it's like, oh, there's another one over there. And it's like, oh yeah, that's a different list for a different thing in a different place. So when the person is at that place, they remember, oh yeah. And they say, oh yeah, I got to remember to do that. Oh yeah, I got to. And I thought, that is really well organized. But I also then started putting it together. It's like, oh yeah, when we're having conversations every once in a while, things do seem to slip. The lists clearly help to jog the memory. And I thought, what a good plan. This person is at a stage in their life where they're, that middle part that I was talking about, where something's going on to where you're no longer able to understand that something's happened. And that middle ground, they've found a way to keep themselves dialed in. And I thought, well, okay, that's cool.
Yeah, and that's quite different from dementia. It was something that we've sort of touched that we might talk on today, is what's the difference between a dementia And you know, a lot of people do tend to lose the memory a little bit as they get older.
Which
But I
doesn't mean you
mean,
have dementia, right?
no, it doesn't, because dementia is more of a pathological process. As you get older, your brain naturally shrinks. It's called cerebral atrophy. And you can also have, again, like little mini infarcts. An infarct is an area where part of the brain has died, it's not had enough oxygen. That does happen, but that's, again, not quite as pronounced as vascular dementia. You know, and we didn't even talk about frontal lobal dementia, which is where you get quite significant personality changes and people can become very aggressive. You know, like these are very set pathological processes. Just general memory loss just happens with general aging of the brain. You know, it'll happen to all of us. I mean, I like to think I'm not too old, but I've even turned into my granddad, and I'm like, Lincoln, Jack, Neve, Florence, Jack. You know, like my granddad couldn't say your name without running through Melanie, Susie, Betty, running through all like the grandchildren, his daughters' names at the same time, and it's like you find that happening quite quickly. That's just a normal process.
I'll be talking to some every once in a while. I'll be talking to someone or something, and you know, I'll just get, what were we talking about again, or what's their name? Well, we just told you their name. Yeah, but it's terrible.
Do you ever get that thing, James, where you know you've known someone for a while and you're in front of them and you suddenly think, I've totally forgotten your name, and it's like, oh my goodness, and then someone's turning up and you think, I'm going to have to introduce them, but I've known them for about 5 years and I totally have just forgotten their name.
Yeah, all the time. Yeah. When good old radio days, I used to always have sticky notes on the thing, and I would write everyone's name in the order because they would introduce themselves. You know, hi, I'm John, I'm Jack, and then they'd all be sitting there. I go, I don't remember anyone's name. It's like, but they just told me their names. You feel so bad having to ask them, so I would always sticky note it up. But you know, yeah, that's just memory loss, and this becomes an interesting thing because as soon as people have memory loss, people start saying, oh, maybe you got dementia coming on. It's like, no, maybe I've just got memory loss.
I think the stigmata of dementia is normally quite an obvious short-term memory loss, and people not even realizing that they've forgotten, and people getting lost in a familiar place. That's quite a common one. And the other one is spatial awareness. So say they're drawing or they're writing, you'll find that their spaces are all peculiar. So for instance, if you ask them to draw a clock, they would have big gaps maybe between the 1 and the 2, but then the 2 and the 3 would be all scrunched up together. And to be honest, I've got no spatial awareness anyway, but I haven't had it all my life. So it's something that is changed and it's different. And these people do need to go and see the doctor, have a full, thorough memory examination, and usually have to have a CT or MRI scan of the brain in order to check that it's not something else that's happening, you know, because you also think these things could be from a tumor. You know, you've got to look into everything, really.
Those tumors. I mean, I don't. It's amazing.
Just those tumors, those ones.
Tumors. You know, they just throw a wrench into everything. We think something's going on, and then you do a scan, and you got a tumor. It's like, I don't want to do a scan. I'm paranoid. They're going to do a scan and find something. You know, just. I don't think,
James. I don't think anybody wants a tumor. Just to clarify.
I know.
And I say that Alzheimer's, as I say, take what I'm saying with a pinch of salt. It can be pleasant. It's obviously not. Nobody really wants it. But I do think at the very, very old age, to be a little bit confused is not a bad thing. Especially if you're the alternative, literally watching yourself not be able to function. You know, I think the reason I give these examples because I have an elderly grandma, and I've told you she is, you know, watching herself, you know, decline and slow down, and I don't think it's very pleasant for her either. But a tumor, nobody wants one of those. Nobody ever wants one of those. No good things come from a tumor, James.
That's it. Exactly. We need to do a whole talk on tumors.
Okay, well, we spoke about oncology, but I guess we've never spoke about brain tumors. And the thing with brain tumors is they can often affect the young as well. It's not something that is isolated to the elderly.
Yeah. Well, I think we got to talk about that. We got to talk about what
that'll be fun and games. That'll be a really, really positive.
Yeah. Oh, that'll get everyone really happy. It's like, oh yeah, that's like when, you know, the word tumor and the word cancer. Either of those come up. Even worse, you've got a cancerous tumor. Oh, that's it. People, you know, that then you break out in a cold sweat. Give me give me how long do I have? What's
What we can have maybe a focus on is the more successful treatments and success rates, because obviously it's not a death sentence anymore. For a lot of people, there are treatments and ways. I mean, some of the brain surgery is absolutely insane, where you can take off a part of the skull, get in there, take out the tumor, and just, a few weeks, pop it back on again. It is remarkable what goes on in the neurosurgery. So yeah, we can maybe look at the more positive side of these things.
Oh man, this has been a lot of fun, Jenna. We talked about some good stuff today.
Yeah, we did. We were more medical. Like, we actually talked about health, which is great.
It's almost like we need to do we also need to do a show. Maybe that's the next one we do, is the terminology from all the doctor shows. You're watching all these medical shows and there's all sorts of terminology and ideas that they're talking about. Let's talk about what you see on TV and what's real.
So when you start medicine, you have to buy your Oxford Dictionary of Medicine or medical terminology. And mine in the first year was completely battered. It was battered because you're reading a sentence and you have to look every single thing up. And then now it's really easy because you don't realize you learn so much Latin. And nobody tells you want to learn to be a doctor or a nurse, whatever, that you're going to learn the Latin language. And I know so much now, because then you'll hear something and you can figure out what it is based on, heme, blood, etc., etc. So yeah, like, that would be quite cool. Let's do that, James.
Yeah, let's do that one. Okay, we're going to do that one next, because I seem to end up watching all these medical shows and it's just like stuff going on and it's just like, really? I see, you can't watch them. Yeah, you see, whereas stuff like anything that's got to do with teaching and professors and stuff, I don't watch those, because I just kind of go, no, I live that world. It's like,
yes. And also, it's not quite, sorry, James, as I'm talking to you, I'm having to send something at the same time. Is that terrible? I'm with you, though. I'm with you.
That's okay. It's just like
life goes on whilst we podcast. I get frustrated about how unrealistic a lot of it is. And if it is realistic, it's usually representative of the NHS in the UK, and I get like heartstrings because I miss it. So either way, can't watch it. And probably a bit similar for you with Professoring.
Yeah, it just, I think it's sometimes even just watching shows like that and having, you go to a doctor every now and then, or if you've ever been to a hospital and you just, you get just getting a blood test, you see how it's done, and then you're watching how they're doing it on some of these shows. And sure, they have people doing, I was watching something yesterday and they were doing a blood test for a DNA sequencing, I guess. And so they obviously had all the stuff on the arm, and there seemed to me there was overkill. There was way too much going on in that arm, but
they have music in the background.
Yeah,
dramatic music. Yeah.
What I kept watching, I missed the dialogue, because I just got to see how they're doing this, because they pulled off obviously one of the vials that had filled with blood, and they shook it a little bit and they put it down and said, okay, that seems right. And then they had another one, and I was just watching to see, are they going to put it in there, and is it going to start to fill, or how have they got this going? And they just cut out at that point, because I'm going, yeah, I want to see how they're doing this piece, because it's, I don't know. Crazy.
I can show you any day you want, James. I love taking blood. Love getting blood. Sure. I'm a bit of a vampire.
I went and had my blood test done because, for visas in the UAE, we get our blood test, of course. And this person did. I didn't even realize it was done. So he goes, okay, it's over. It's like, what do you mean? It's like, when did you do it?
You've got good veins.
Yeah.
Madonna gets a bad rep for her veiny arms. I tell you what, I've got no problem with having veiny arms. People can laugh at me as much as they like. If there was an emergency, I'd be the one that's getting the cannula straight away and the medication that I need. So let's give Madonna less of a hard time. Those veins are going to save her life one day.
Oh man, Jenna, you know what? This has just been fun, but as much as this has been fun, I know that you've got things to do. Neve has been spectacular, but that means she's going to wake up any minute now.
Oh, she does immediately. Look, here we go.
Oh, there we go.
To be honest, James, this will come to an end at some point. We've had a really good run of Neve being asleep during the podcast. Let's see how long we can go.
Yeah, for sure. There we go. I'm going to let you go, though. But you've been listening to Talk with Dr. Jenna Burton. Find us across the socials, PODAHOLIKS with a K. And of course, you want to get in touch, PODAHOLIKS with a K @gmail.com. Dr. Jenna Burton, James Pikeway. We're going to do it all again real soon. This has been Doc Talk, coming to you in the Zoom sphere.